Good day, ma'am. I'm Raquel May Ragudas Hechanova from Convent C, and today I'm going to perform Physical Assessment 3. So first, state the purpose of the procedure. Number 1, to continue assessing the rest of the musculoskeletal system, to obtain baseline data about the client's functional abilities, such as normal anatomical functioning of the extremities, to include color, symmetry, flexibility, range of motion, muscle strength, reflex, and others. Measurement of the upper and lower extremities to include normal range of joints. To supplement, confirm, or refute data obtained in the nursing history. To obtain data that will help establish nursing diagnoses and plans of care. To evaluate the physiological outcomes of healthcare and thus the progress of a client's health problem. To make clinical judgments about the client's health status and to identify areas for health promotion and disease prevention. Greet the client and introduce yourself to establish rapport with the client. So, good morning, ma'am. I'm Raquel Mehechnova, your nurse practitioner for today. Identify client using 2 identifiers to establish client's identity or ensure the right client. May I know your name, ma'am?
Magdalena Isanaba po,
How about your birthday?
May 29, 1969.
Okay. Explain procedure to the client. Knowledge about the procedure facilitates cooperation. Perform hand hygiene and observes other appropriate infection prevention procedures to prevent transmission of infection. Provide client privacy to promote dignity and prevents embarrassment. Ask client for medical history. Provides information on the risk factors of the related to physical assessment 3. For the inspection, shoulder to wrist, in the dorsal aspect, ask the client to raise both arms at the chest level and the palm joined together and support client's arm if necessary. When looking at the patient from the anterior view, the examiner should begin by ensuring that the head and neck are in the midline of the body and observing the relation to the shoulders. The examiner should note any abnormal bumps or malalignment in the bones that may indicate past injury, such as a healed fracture of the clavicle. In most people, the dominant side is lower than the non-dominant side. While observing the shoulder, the examiner should look for the possibility of a step deformity. As the patient elevates the upper extremity by abducting the shoulder, the examiner should note whether a painful arc is present. A painful arc may be caused by a subacromial bursitis, calcium deposits, tendinosis of the rotator cuff muscle, or most commonly by an unstable scapula. The pain results from pinching of inflamed or tender structures under the acromion process and the coracoacromial ligament. So, ma'am, itaas nyo po yung braso nyo at the chest level po, and pagdikitin nyo po ang inyong palad. Okay po. Next, spread nyo po yung arms nyo. Taas nyo po. Thank you po. Baba po. So, there is no step deformity, sulcus sign, subcoracoid dislocation, and no painful arc. Tapos, next po. Take note of the length of the client extremities. For any discrepancies, measure the muscles with a tape. Atrophy or hypertrophy, asymmetry. Inspect the muscles and tendons for contractures or shortening. So inspect There are no discrepancies po, atrophy and hypertrophy asymmetry. Okay. Next, describe the general appearance, skin, color, hair distribution, discoloration, presence of moles, scars, and veins. Skin colors varies from light to deep brown, from ruddy pink to light pink, from yellow overtones to olive. Deviation from normal findings, pallor, acrocyanosis, jaundice, and erythema. Areas of either hyperpigmentation or hypopigmentation. Presence of edema, malformations, freckles, some birthmarks that have not changed since childhood, and some long-standing vascular birthmarks such as strawberry or port wine hemangiomas, some flat and raised nevi, no abrasions or other lesions. Note that if agency policy permits and the client agrees to take a digital or instant photograph of significant skin lesions for the client record, include a measuring guide, ruler or tape in the picture to demonstrate lesion size. If skin lesions are suggestive of physical abuse, follow state regulations for follow-up and reporting. Signs of abuse may include a pattern of bruises, unusual rotations of burns, or lesions that are not easily explainable. If lesions are present in adults or verbal age children, conduct the interview and assessment in private. Normal hair is resilient and evenly distributed. So, okay. Your skin color is brown. There are no presence of edema, no malformations and skin lesions, but freckles are present. Hair is resilient and evenly distributed. For the shoulder to wrist ventral aspect, ask the client to turn arms still at chest level. When viewing the patient from behind, the examiner again notes bony and soft tissue contours and body alignment, especially scapular mispositioning. Active extension is normally 50 degree to 60 degree. The examiner must ensure that the movement is in the shoulder and not in the spine, because some patients may flex the spine or bend forward, giving the appearance of increased shoulder extension. Weakness of full extension commonly implies weakness of the posterior deltoid in the arm and is sometimes called the swallowtail sign, because both arms do not extend the same amount, either due to injury to the muscle itself or to the axillary nerve. Itaas nyo po yung both arms nyo hanggang sa nakakaya nyo po. Thank you po. There is no swallowtail sign. Extension is 50 degree to 60 degree, and movement is in the shoulder. Describe the general appearance. The scapula is parallel to the spine. For the hands, describe the general appearance. Inspect the position of the hands in motion for a smooth, natural movement. When the fingers are relaxed, they should be slightly flexed. The fingernail edges should be in parallel. Patingin po ng kamay niyo, ma'am. Finger ng kamay niyo. Ganito po. Okay. The hand moves smoothly po. The fingers are slightly flexed and parallel to each other po. Next, count the number of fingers. Usually, part of newborn assessment, it is done to determine presence of congenital absence of extremities, including fingers, due to thalidomide ingestion during pregnancy, or it may occur spontaneously. Phocomelia is a rare congenital defect defined by the absence of intermediate segments of the extremity. Children with phocomelia present with their hands or feet directly attached to the trunk. Phocomelia is famously a teratogenic side effect of the drug thalidomide, a drug first marketed to treat anxiety and morning sickness. Other related conditions are polydactyly, syndactyly, and club hand. Palayin ko ulit ng kamay na. Okay. Fingers are complete pa. Next, describe the nails, the color, shape, or curvature. Tingnan po ulit ng kamay na. Nails are colorless po and have a convex curve, and the nail bed is 160 degrees. There are no signs of clubbing, and quickly turn back to its usual color while pressure is released. In palpation, in shoulder to fingertips, describe the skin temperature, skin turgor, presence of masses, lumps, areas of tenderness, muscle size, and tone. Check ko po yung temperature nito. Okay, kabila pa po. Upper extremity are warm to touch, no mass or lumps can resist applied counteraction po. Next, perform capillary refill test. Check ko po yung nails nito. Okay, kabila po.
Mamatay ang kilid ko.
It returns to its usual color in less than 2 seconds po. Next, in range of motion in upper extremities, instruct the client to raise both arms to vertical position at the side of the head. Place hand behind the neck. Raise niyo po yung hand niyo, tapos, gayahin niyo po, ganito pong gagawin. Any pains po? May naramdaman po kayo?
Wala.
Okay. There is no presence of pain upon doing the activity. Next, in shoulders, instruct the client to abduct and adduct shoulder. When observing multiple movements, the examiner may ask the patient to perform them in combination, especially if the patient history has indicated that combined movements are bothersome. Alple's scratch test combines medial rotation with the adduction and lateral rotation with abduction. This method may decrease the time required to do the assessment. In addition, by having the patient do the combined movement, the examiner gains some idea of the functional capacity of the patient. Gaya niyo po yung gagawin ko. Ito pa. Tapos, yan po. Tapos kabila po ulit. Masakit. May naman po kayo masakit?
Wala po.
Wala po. Okay. Next. Instruct the client to rotate the shoulder internal or external. Often, the dominant shoulder shows greater restriction than the non-dominant shoulder. Even in normal people, an exception would be patients who continually use their arms at the extremes of motion in, for example, the baseball pitchers. Rotate po your shoulder inward and outward po. Okay po. May masakit po na ano? Wala po. Okay po, there are no painful complaints. Next, in elbow, instruct the client to bend and straighten elbow. The patient must be stayed suitably undressed so that both arms are exposed to allow the examiner to compare the two sides. The examiner first places the patient's arm in an anatomical position to determine whether there is a normal carrying angle. Gamitin niyo po ganitong kamay niyo. Then, fold po. Isa pa po. Isa po. Okay. The active elbow flexion is 140 to 150 degree po, and the extension is up to 10 degree po because the patient is woman. Next, for the wrist, instruct the client to flexion and expand wrist. The functional position of the wrist is extension to between 20 degree and 35 degree with ulnar deviation of 10 degree to 15 degree. This position, sometimes called the position of rest, minimizes the restraining actions of the long extensor tendons and allows complete flexions of the fingers. Thus, the greatest power of grip occurs when the wrist is in this position. When the wrist is in this position po, ganito po kayo, ma'am. Ganito. Tapos, try mo po i-flex and extend po. Straight lang and out. The wrist extension is 70 degree. Tapos po, the flexion is 80 degree. Next, instruct the client to rotate wrist. As the patient does the various movements, the examiner watches to see whether the components of the wrist move in normal coordinated sequences and whether the patient exhibits any apprehension when doing a movement. Rotate po yung wrist nito. Rotate. Rotate po. Okay. Wrist move in normal condition. For the hands, instruct the client to extend the arm. The dominant hand tends to be larger than the non-dominant hand. Next, spread fingers. Normally, when the hand is in the resting position and the wrist is in the normal position, the fingers are progressively more flexed as one moves from the radial side of the hand to the ulnar side. Use of this normal attitude may be caused by pathology affecting the hand, such as a lacerated tendon, or by a contracture, such as Dupuytren contracture. Extend arm po, ma'am. Okay. Then, extend the fingers. The dominant hand is larger po. Next, test hand grip strength by asking patient to grasp the second and third finger. This test functions of wrist joints, the finger flexors, and the intrinsic muscles and joints of the hand. Pisilin mo po yung fingers. Hand grip strength are normal. Next, make a fist. The patient should actively perform the various movements. Initially, the active movements of the forearm, wrist, and hand may be performed in a scanning fashion by having the patient make a fist and then open the hand wide. Make a fist, ma'am. and open wide po. Saka po. There is no restriction, deviation, or pain. Next, thumb across the knuckles. Thumb across the knuckles. The cracking of knuckle cracking seems to be produced by increasing the space between finger joints. This causes gas bubbles in the joint fluid to collapse or burst. It's a bit like blowing up a balloon and then stretching the walls of the balloon outward until it pops. Put your thumb po inside the knuckles po. There are no cracking of knuckles po. In inspection, in ventral aspect, ask the client to stand with his 2 feet together. Describe the general appearance. In postural assessment, from the posterior view is similar to that in the anterior view. Shoulder position, knee interface, and ankle position are all assessed, in addition to the overall symmetry of the body. Stand po kayo with your 2 feet po. Pwede ka pinita yung 2 feet mo. Okay po. Ito na po kayo. Count the number of toes on each foot. Describe the nail, color, and curvature. Complete number of toes and convex curve. In dorsal aspect, stand at the back of the client. Describe the general appearance. The major advantage of this posterior view are additional information regarding heel position and scoliosis screening of the spine. Ankle positioning in the posterior view allows assessment of the heel. If the heel is tilted inward, such as a horse with pes planus, the term hindfoot bulbous is used to describe the abnormality. Conversely, a heel tilted outward is termed hindfoot varus. Tayo ito kayo ulit. Up. Okay po. Thank you po. There is no hindfoot valgus. Ask the client to flex the leg, then describe the soles of the foot in terms of color, presence of veins, callus. Then repeat the procedure with the other leg. Soles of the foot are usually coated with minimal callus, yellowish in color, free from any mass or lumps or any of the signs of inflammation. Tayo po ulit kayo. Tayo po ulit kayo. Mali yun. Then flex po yung arms, yung ano na po yung sige po. Okay po, yung kabila naman po. Okay po. There are minimal callus, yellowish in color po, free from any mass or lumps. There are no any obvious signs of inflammation po. And there are no plantar fasciitis po. Next. Perform hand hygiene to prevent spread of microorganisms. Document findings in the client record to serve as basis for proper evaluation and management of client's condition. Thank you.